Welcome to Healthy Focus, the Duke Rawling Hospital Community Education Series.
Please join me in welcoming Dr. Michael Haglund.
Can everybody hear me in the back? Can you hear me back there? Yes? No? Good, okay. Well, it's a pleasure to be here. Tonight we're going to talk a little bit about neck pain. I deal with it every day. I do about 300 of these surgeries a year. I've done about 4,500 since I've come to Duke. It's one of them, in my 10 surgeries every week, this is 6 of them. So I deal with all sorts of patients coming from all sorts of time periods. What I wanted to do today, so just an aside, a rabbit trail. I'm doing my master's in academic medicine right now at the University of Southern California, and we meet on Monday and Thursday nights. And I've learned a lot already, and so when I went to get ready for this talk, I go, okay, I have my talk I gave, to the nurses. This will be good. Just, make it appropriate for everybody. And I remember reading in my coursework so far, I've only been in it for 2 months, that learners don't do very good if you just talk to them for 45 minutes and then answer some questions. That's kind of painful. And so one of the ways we can learn better is we can be interactive. So can you just hand me do you have one more clicker left? Can I just have your clicker just for a second, or somebody's clicker just for a second? One's good. So on your clicker, you just push one of the buttons to activate it. In the middle, just push like 2B to activate it. And then you should see something pop up, and it'll say like not accepting answers right now. You'll see the little numbers by the side, like 1A, 2B, 3C, 4A. If you're putting, you'll see the numbers on the side in just a second, so we can try this. Can everybody you see this? Okay. Do you have a neck? Okay. Polling's open. You just would push the 1A. Here's your button back, ma'am. You can have yours back. You just would push that 1A button, and then when we're done, everybody got it. So I can see how many people have answered. Only 50 have answered. So everybody get in. Just push the 1A. That would be yes, you have a neck, because otherwise you'd be in a stretcher without, or probably not alive. Okay. So you push the 1A. Everybody got it? Anybody have any problems with it? Everybody gotten it? Getting it? Just push one of the buttons and it should turn on. Not on. Do we have any more of those? I mean, there should be a few more in the back. It doesn't say. You just push it once and see. You can see. So 54 people responded, and then we can. Okay, we set. So then I do this, and okay, 4% doesn't have a neck, so that's not the bad thing. I can tell a story about that when we were in at a meeting. One of the big professors in neurosurgery was giving a talk, and there was a couple of us where I did my fellowship at Mass General, and we were sitting in the back, and we had a bunch of these clickers, and he'd say, well, what do you think the approach should be? And then the E was no surgery, and we'd push like 5 of them, and like 10% would show no surgery. How can you decide that there's not surgery necessary for this? So try to answer honestly. All right, so let's do this. What is your age? Let's try. Oops, I messed up. Okay, let's try what is your age. Now you see, now you just would answer the A or the B or the C or the D. You're getting it now. Look at all those answers flying in. I tried to be appropriate and not insult anybody, but okay. So this is just to get us an idea, because you'll see why we're going to do this in a little bit. So I want you to really understand. By the time we're done, I want you to understand when you present with certain things, what should your next step be. So there we go. So nobody 31 to 40. Good population here, and 61 and over. That's great. Okay. How about this one? This one's pretty easy. Do you currently have any neck pain or arm pain or numbness, and that's why you're here kind of trying to find out how this all works? So it's either A or B on that little button, 1A or 2B kind of thing. Everybody getting it? Any questions? Anybody need help? Because I want you to we're going to be doing a few of these, so I want everybody to understand this. Okay? So there we go. Okay, so a lot of you are here, and as you can see, everybody sitting next to you is probably having neck pain or arm pain. And then, okay, let's talk about this finally. So are you currently getting treatment for any of your neck pain? And polling is open. Everybody's getting this now. Now you're getting the swing of things. it's just A or B. Once you get used to this, we use this all the time with our residents and things like that. If you don't get in, it's okay. I mean, it's, again, we're not recording your exact seat assignment and what you're doing kind of thing. So 76%, so that's interesting. And how about this last one? Have you had surgery before on your neck? So now it's not working and you're here to find out what to do next. Okay, whoever number 54 is getting in slow. All right. So most of you have not had neck surgery, so that's interesting. All right. Let's just skip this one. Let's talk about some of the key points we're going to talk about tonight. We're going to talk about the anatomy of the neck. We're going to talk about stability, and we're going to talk about, anatomical complications on which way we approach this. And then for a little bit tonight, you're all going to be like honorary neurosurgeons. So let's start out. A lot of people develop degenerative neck disease over time. We saw that in our room here tonight, 68% of the people were 60 and over. Well, unfortunately for you, 75 to 80% of you are going to have degenerative neck disease already by the time you're 65. And this just happens over time. The discs wear out, they dehydrate, you develop instability. And we kind of break the neck down into, well, why did I get this? Well, patients always ask me that. It's kind of 3 phases. I kind of put it in one phase as genetic. Well, how can it be genetic? Well, people get degenerative disease genetically. You have all your brothers and sisters have had back surgery or lumbar fusions. I take the example of there's the Southern Belle sitting on the front porch. She's never done a lick of work in her life, and she develops really bad neck pain and degeneration when she's in her late 30s. Then you have the guy on the construction crew throwing 10,000 bricks a day up to the guy on the scaffolding, and he never has a problem. Well, that's got to be good genes on his side and bad genes on our Southern Belle side. Then there's just the wear and tear phenomenon. Over time, using your neck a lot, and it doesn't mean you have to be running a jackhammer all day or something like that. I had the greatest example. I had this 38-year-old lady. She was perfectly fit. She comes in, she sits down. Her neck looked terrible. This was like about 3 months ago. I said, well, what do you do for a job? Well, she says, I used to play tennis. I go, what do you do now? I'm a tennis official. So what is she doing all day? Well, I mean, all day long, that's her job. So it's not surprising her neck looked like it was 70, not in her 30s. And what about the disc? Well, it's made up of a couple things. If you think about it this way, it's made up of some round fibers, if you're looking down on top of the disc, some round fibers that are called the annulus. And in the middle is called the nucleus. It's the soft part of the donut, the middle of the donut. And that's what gives it some spring or motion. And that can degenerate over time. The proteins decompose, you lose hydration in the disc, and it loses some height. So all of us, as you know, when you get older, you get a little shorter. It's because you have all these discs in your back and they're all dehydrating and they're shrinking down a little bit. One of the jokes we tell our patients when they're having surgery, the good news is we did a 3-level fusion on you and now you're, like 1/8 of an inch taller because we jacked those spaces open for you. There's joints in the back that can develop degeneration from arthritis or some congenital arthritis, like ankylosing spondylitis, or you have some type of osteoarthritis, just like you have in your joints in your knuckles. You can get those same degenerative joints in your neck. And then you have ligaments in the back that can be injured. Let's say the third component of the genetic, the wear and tear, is intermittent types of injury to your neck. I was playing football when I was in high school and I got a stinger. My neck really got twisted and my hand went numb and my arm went numb, but it got better and I never thought about it. Well, that injury may have caused the disc to start degenerating, so instead of giving you a problem when you're 70, it's going to give you a problem when you're 60. Now you have these ligaments in your neck. I can use this as a pointer. Yeah, you have ligaments in your neck. And if these are the bones in the front, so this is the front of your neck, this is the back of your neck, here's your skull up here, you have the bones, we call them cervical, so we'll be talking about, you have 7, C1, C2, C3, C4. You have a ligament that runs in the front called the anterior longitudinal ligament. You have one that runs behind the bones all the way up and down your spine called the posterior longitudinal ligament. And then you have ligaments sort of connecting the spinous processes in the back you can feel. There's also this transverse ligament. The first thing you need to know is, how does your neck move? So when you move your head like this, 50% of that motion is where your skull is fitting on your spine. That's where that 50% of that motion is. When you turn your head left and right, 50% of that motion is where C1 meets C2. And you can kind of see this. This is looking at a front view of your spine. Here's C2, here's C1. C1 sits like a little ring around C2, and it kind of pivots on it around back and forth from left to right. So here's a question. I don't think you have to poll on this one. This person's spine, he was in a motor vehicle accident. He was a pedestrian. He got hit at high speed by a car. Do you see any problems there? Like his head's no longer connected to his spine. So this is C3, C2, and there's supposed to be C1 there, but it's way up there. And this person was completely quadriplegic, but fortunately or unfortunately for him, we saved his life and basically settled his head back down onto his spine. So these can be injuries you get. And then you can also have, like this one, there's a simple one here. We talked about that. We don't have to go over that. What are the symptoms you have with your neck pain? Well, you can have pain in the muscles on the side. Paraspinous muscle pain is very common from a neck strain. You slept wrong. You had a little crick in your neck. That's on the sides. You can have headaches with that. It's because your muscles of your neck all attach back here, right in the back of your skull. And so if they're spasming, it's going to pull tension on that, and you get these terrible tension headaches that are very common with neck pain. But they're usually in the occipital. They're not out on the side. They're not migraines. You don't usually have light sensitivity like migraines. And then you can have pain in your neck that's exacerbated by motion. And one of the more common referrals we get is from, someone's been worked up and they had their shoulder operated on and they had their labrum fixed and they're still having neck pain and arm pain, and it was in their neck, not in their shoulder. What about, we talk about this word radiculopathy. That's basically one of the nerves in your neck is getting pushed on. And we know where those nerves all go. And we'll talk about those in a second. And then what happens, and it's really common, people say, and this is the most common story we hear, I was doing fine, I never had a problem, I went to bed that night, I woke up and I had a crick in my neck. And it just didn't get better. Like I wake up with cricks in my neck. I jokingly say to people, my Motrin's usually not more than 15 feet away from me. It's in my backpack, it's in my nightstand, it's in my golf bag. But the point is, my neck hurts after being 12 hours in the OR. What do? I go home and take 3 Motrin. Well, I don't have kidney problems, I don't have ulcers, so it's okay to do that. But it's probably more psychological than real, because 5 minutes after it's in my stomach, my neck's already feeling better, and it couldn't have been working by yet. It's probably still sitting there as 3 little pills in my stomach. But it's usually a dull, aching throbbing. You may get a burning sensation going down your arm. And it can be referred some places. It can be referred between your shoulder blades. It can be referred down into your chest. It can be referred out your arm. And based on where it goes, we know usually what disc that is for the neck. And we can pinpoint it even before we see the MRI scan. Now, one that's a little more serious is something called myelopathy. That means something's really pressing on your spinal cord. It's not just hitting the nerve after it's leaving the spinal cord. It's hitting actually the spinal cord. And those are the people you worry about. Those are more emergencies. Those are ones not to mess around for 6 months doing non-operative management, because and they usually show up with numbness and tingling in both hands. Common thing I'll ask somebody, somebody comes to my office, they're sitting there in a t-shirt. They're usually a well-dressed guy looking like they're in their 50s, and why are you wearing a t-shirt? And you find out, well, I can't do my buttons. I can't do my fine buttons anymore because my fingers are kind of numb all the time. They don't feel coordinated. My gait kind of feels wide and broad-based and not steady. And that's the most common thing we hear. And the other worst thing we don't want to hear is, oh, I bend my neck, Dr. Haglund, and I get these shooting, like, tingles going out my arms and my legs, and that's because you're squishing your spinal cord. So that's a serious thing. What do we look for on a physical exam? We look for joint pain in the back by just palpating. So for us, it's a lot more serious if the pain's right in the midline on the bone than it's off in the muscles. These muscles will hurt if they're spasming, but if you're pushing on the bone back there and people complain of very severe pain, that's more worrisome. We also can tell on, like I said, by which nerve's being pushed on, we can tell, give an idea where you're complaining, which nerve it is. So the upper nerves are not so helpful. C1 and C2 kind of go to the back of the neck. That's not that helpful. C3 may even go up to the back of your ear. C3, 4, pretty uncommon, but it usually goes into your scapula between your shoulder blades. Now the ones that are more common are these next several. C4, 5, the disc, if that disc is pushing on your nerve, you get it out into your shoulder and you get a weak deltoid muscle. So if I hold your arms up and try to push them down, one might be weak. Or if I put your arms together like this and you try to push out while I push in, your arm collapses. Now it could be a rotator cuff too, if I can find some point tenderness, but if that arm's just generally weak, then that might be a C4-5. C5-6 is the most common one. We have a little thing we teach our residents, easy to remember. If you can make, this, if you make your thumb goes in and makes a 6, it affects your index finger and your thumb, and it's your biceps. So if I test your biceps on one side and it's your dominant arm, let's say your right arm, and I can pull on that and it kind of gives away, not jerks away because the pain hurts, but just kind of gives away and your left is real strong, I'm thinking a C5-6 level. And it'll give pain and numbness into these two fingers. 6-7 is the second most common one. And the difference between 5 and 6 usually goes down the front of your arm and gets into these two fingers. And 6 and 7 usually goes around your shoulder blade, comes down the back of your arm, and gets into kind of these 3 fingers. I guess I shouldn't tell you this, but we can figure out if someone's kind of trying to make it up, because it turns out that C6 nerve from the C5-6 disc goes to these 2 fingers. C7 gets this finger, but it only gets the inside part of this finger. C8 gets this, so you're testing somebody's numbness, and it's numb, and then you go over here and you go, you feel that? No, it's numb. And you feel that? Well, yeah, I do. And it's like, oh, that's right. That's because C7 doesn't get the outside part of that finger. We can have somebody, usually people will come in with a herniated disc or a bulging disc that's pushing on something. It will, if they cough or they bear down to have a bowel movement or they sneeze, they get this terrible shooting pain in their neck. One of the ones we worry about is called this Hoffman's reflex. No offense to some of my colleagues, but a lot of people don't check this. But that's the thing we're looking for to see if they have pressure on their spinal cord. If you have pressure on your spinal cord up at the top, and I take your hand, it's all relaxed, and I flick it, and your hand goes like that, that means there's pressure on your spinal cord, and that's significant. Same thing, if we tap on your reflex, it should kind of give you a little jerk, and your whole hand clamps. That also tells us there's pressure on the spinal cord. So what do we do with these patients? Well, the thing I tell people is the majority of patients, will get better in 6 weeks. So what I tell my patients, you wake up, you have a crick in your neck, you have neck pain, maybe a little arm pain. You don't need surgery that morning 99% of the time. But what I tell people is whether you go to the chiropractor or the physical therapist or the acupuncturist, or if it's your left arm, you carry around my magic tuning fork and you get up at 6 in the morning and walk around your house 3 times, you're going to get better in 6 weeks. Why? Because everybody gets better in 6 weeks, 80%. So by 6 weeks, it should be going away. Now, you may have taken some anti-inflammatories or done something, we'll talk about that. But most people's pain and an aggravation of a muscle strain or even a little tiny disc bulge that tore a little bit will go away in about 6 weeks. 90% are gone by 3 months. So the people I don't want to see in my clinic are people who've had neck pain for doctor, it started Monday and it's like Wednesday evening, it's not gone away yet. It's like, okay, well, first of all, you need a lot of conservative therapy. Second of all, your insurance company is probably not even going to pay for you to see me because you should have been seeing somebody like your PCP, not a neurosurgeon. But most of them will go away. Sometimes we treat people with a soft collar. Most of the time we don't because we want them moving their neck. The biggest thing we use, first line of thing, is non-steroidal anti-inflammatories. You got to make sure you don't have kidney disease, you don't have ulcers. And my advice to people usually is if you take ibuprofen, if they're 200 milligram tablets, if you take 3 of those, which would be about 600 milligrams, don't be like, okay, this is recording, right? So I won't say the person that lives in my house, but she's much lighter than me, but she takes like a 200 milligram pill, and I'm going, okay, well, you might as well just wish yourself good luck and throw it over your shoulder, because that's what we give to little infants and babies. So if you're expecting that to help, it's probably not going to help. So 600 milligrams works really well for adults. You don't need 800. Why don't I use 800? Because if you take 600, you can take it with breakfast, so it's on a full stomach, with lunch, full stomach, dinner, full stomach, and maybe with a little snack at night. But if you take, why is that going forward? Is it like on a timer? If you take 800 milligrams, you take it with breakfast, 2 in the afternoon, empty stomach, 10 at night on an empty stomach, and it can upset your stomach. Sometimes people use pain medication to control their pain. A lot of times if you're having bad pain and it's not going away, they'll put you on some oral steroids, Medrol dose pack that lasts about 7 days. And then finally, Sometimes we'll talk about epidural steroid injections, and we'll talk about that in a second. One of our most common things to do is, if you're not getting better over the first week or so, is to start some physical therapy. And they can do postural awareness, getting you in good position. They can do strengthening of your muscles and isometrics. They can do heat-cold massage. They can do acupuncture. They can do cervical traction. Cervical traction at home looks like he's hanging himself, but he's only got a 10-pound weight, so it won't really work. To put someone in traction, usually your head weighs about 10 to 15 pounds. So 10 pounds of weight is about the right weight, and you hang it over your door, and it just stretches things out, loosens up the muscles, and a lot of times that helps people. And then injections. Some people go for epidural injections. I mean, I'm going to put a disclaimer on this after seeing hundreds of thousands, of patients and injections. I think they're a little bit dangerous unless they're kind of done under someone who's very experienced or done under CT guidance. Sometimes they'll do it with a fluoro machine. And when you think about it, that little needle is really, really close to your spinal cord, and any little miss we don't want to miss. So that's another possibility. So that's kind of our lines of treatment. Chiropractors, okay. I'm not a big fan of the big neck twists. I mean, the famous story I tell everybody, we were at a soccer tournament with my son when he was younger. Everybody was asleep in the bed. I was up working, and on TV was Alan Alda on PBS doing some non-traditional treatments. And they showed a chiropractor doing a neck manipulation. I go, oh, this would be great to watch. I want to watch this. And they got him, and they did something like I've seen more on Born Identity. They went, and I was like, oh, I went, whoa! And everybody woke up in the bedroom because I was watching TV. What's wrong? I go, nothing. I just saw what they did to people's necks. I don't really think I want my patients having that. But they do good stuff. They do basically, think about it this way. Anything you do, you're having neck pain, it's getting stiff, you're moving less, you're getting more pain, you're getting more stiff. Anything that breaks into that cycle, whether it's my magic tuning fork, a chiropractor, or whatever, that gets you going, I'm moving more, I'm less stiff, that's a good thing. So I think they do a good job, and the ones that are legitimate do a very good job. So here you are. You're all going to become, how many of us, you're all going to become honorary neurosurgeons for the next few minutes. And we're going to review a little bit about what we talked about. So we have to all say this pledge. I do hereby promise to only practice neurosurgery in the basement of the Cancer Center, Duke Raleigh. I will not stay in a Holiday Express or buy an internet neurological surgery training certificate. And at the end of the session, I will return my clicker, because I'm going to get killed if you don't return them, and my temporary neurosurgery license, okay? So, you ready on the clickers? Here we go. All right, case number 1. 38-year-old wakes up with neck pain, and it does not resolve over the next week. What should they do? See a chiropractor, do physical therapy, cervical injections, surgery, or none of the above? There's no necessarily right answer, but just see what you think. I'm just trying to see what you think. There's a necessarily a wrong answer. Okay, Mr. 51, 52, 53, get in there. All right. Exactly. So that's exactly right. Most everybody's got that. Really, you should just give it a little more time. I mean, a week's kind of that margin where, yes, if somebody said you should maybe now go get physical therapy, I think that's totally legit. Surgery, definitely not legit. Seeing a chiropractor, sort of like going to physical therapy. So I don't think those answers are necessarily wrong, but that's why I put that question in there. Okay, case 2. Now, our 38-year-old, after 2 weeks of non-steroidal anti-inflammatories, a Medrol dose pack, no better, now what? See a surgeon, see a non-operative physiatrist who can prescribe physical therapy, primary care doctor and PT, or cervical injections. What does everybody think? You guys are getting good at this. I could bring you on the road with me. Honorary neurosurgeon degrees are so far pretty successful. Let's see how we did. Awesome. So yeah, I think either one of those are fine. A non-operative physiatrist, knowing me, Mr. Specialist, I'd probably go see